For the next session, I would like to welcome and hand over the session to Professor N. Rajendran sir and Dr. Dharmarajan sir.
Move on to the next sessions, and this is the first topic is monogenic diabetes. What is new? Say the monogenic diabetes is a terminology that is become popular in the recent days, which occurs due to some aberration in the genes and result in MODY, neonatal diabetes and syndromic diabetes, etc., etc. And so far, because of late previously about only some 5 to 6 genes has been elaborately studied, and now till recently 40 genes have been studied well. In fact, the same topic with the same speaker actually 2 years back in the Future of the Diabetes conducted by the government of Tamilnadu, and Dr. Mohan only, he spoke about this topic. In fact, during today's breakfast time, I said thing, but Dr. Mohan said, yes sir, but in between so many new concepts have arisen, and the details of which Dr. Mohan is going to talk. And regarding the speaker, Dr. Mohan, I need not elaborate.
I think we can skip the introduction.
So he is very popular and he is well known to everybody. So I will hand over the mic to Dr. Mohan to go ahead with his topic.
Thank you, Dr. Rajendran and Dr. Periyandavar and Dr. Dharmarajan for chairing the session. And I'd like to express my heartfelt thanks to all the organizers, whose names are shown here, for organizing this wonderful TRAC 2025, which is very well attended. And thank you for asking me to talk on monogenic diabetes, what is new. I have no conflict of interest to declare. All these are government funded studies. So let me straight go into the topic, what is monogenic diabetes? Monogenic diabetes is not the commonest form of diabetes. Only 1 to 2% of all diabetes that we see. However, the problem is that it is misdiagnosed. It is missed in about 90% of cases. Usually it's diagnosed as type 1 diabetes. Now that's where the problem comes, because if you don't have type 1 diabetes and you diagnose monogenic diabetes as type 1 diabetes, you will start treating them all with insulin 4 times a day when they don't need it at all, when they can be converted to tablets. That's why I'm talking on this. I first heard about monogenic diabetes when I was just entering my final year of MBBS. I'd already been working for a few years with my father before that, and I saw this report by Stefan Fayans and Robert Tattersall published in Diabetes. I used to read all the diabetes literature as a medical student. They described 26 cases. Now at that time, the term MODY, maturity onset diabetes of young, it's MODY, not MODI. So MODY was first introduced at that time, and why it was introduced was because anything below 40 years was called as growth onset diabetes, and anything above 40 years was called as maturity onset diabetes, supposed to be equivalent of type 1 and type 2, which means anyone in the world diagnosed below 40 years was thought to have type 1 diabetes at that time. So Stefan Fayans and Tattersall said, no, we have got cases, they had 26 cases at the time, which are young, occurs in adolescence and early adulthood, but they are not at all on insulin. So they said not everybody below 40 years is having growth onset or type 1 diabetes, and so they gave a new name for it. They can't call it maturity onset because it's below 40 years, so they said maturity onset diabetes of young people. So MODY, that's how the term was coined. This is the criteria which they set down. Obviously it has to be below 25 years of age. It goes through 3 or 4 generations. So autosomal dominant inheritance, no ketosis, therefore it's not type 1 diabetes, no beta cell autoimmunity. At least 5 years you should be able to control without insulin, which doesn't happen in type 1 diabetes. Insulin secretion is the main defect. They don't have much of insulin resistance, and there's no obesity. So it's not type 2 diabetes as well. So very clear criteria. Of course, these criteria were valid then, After the genes were discovered, you cannot diagnose MODY on clinical criteria anymore. You have to do genetic testing. The first gene for MODY was described in the year 1992. So until then, nobody even accepted the diagnosis of MODY. They said there's something like type 2 diabetes. It was called NIDDM at the time. There's nothing but NIDDM. Why are they calling it MODY and so on? But since the criteria of Tattersall and Fayens was there, just after my MD, I started publishing a series of publications on MODY from India. And I said this kind of diabetes occurring at young age, if you're calling it MODY, it's highly prevalent in our country. Actually, it turned out that many of them actually had type 2 diabetes because we didn't do the genetic tests at that time. So, a series of publications I published at that time. Then the first gene for MODY was described, MODY1, in 1992, and by 1993, 94, 95, several MODY subtypes. In fact, 14 different MODYs were described. More recently, MODY 7, 9, 11, and 14 have been dropped. They are no longer MODY, we cannot diagnose them. So that left 10 MODY types, of which MODY 1, 2, 3 are the most commonest, and they will be about 90% of all MODY will be in the first 3. MODY 1 and 3 are very important because both of them respond to sulfonylurea. They are usually diagnosed as type 1 diabetes. If you make the right diagnosis, you can stop insulin and treat them with tablet. MODY 2 is even more interesting because they don't need any treatment. They can be treated just with diet and exercise. They don't need any pharmacotherapy. I'm not going to the other MODY types. You may say, well, if you suspect MODY, why don't you try sulfonylurea? You can't, because in MODY 10, it's an insulin gene mutation. It behaves like type 1. They need insulin. So you really have to make, this is what precision diabetes is all about. So we published a series of publications. Those were without the genetic finding of MODY. With the genetic confirmation of MODY, I then published a series of papers on MODY 3, MODY 1, MODY 2, MODY 5, and then we did a whole genome kind of analysis of all the MODY genes that was published in BMC Medical Genetics. But the latest paper was published in June of this year. This is a pan-India study. So I wrote to all the members of RSSDI and said, if you have any MODY cases, you can collaborate. And something like 65 people from all over the country send me samples of MODY. So this became the first pan-India study of MODY, and you can see from all parts of the country, the cities and the number of centers from which these samples came. And this was just published, and we found 120 new cases of MODY which we found in this series, of which MODY 3 is the commonest, MODY 1 is the next common, MODY 5 is the next third commonest. So MODY 5 has genitourinary problems. So you will find either one kidney absent, or a horseshoe kidney, or uterus being absent, or some such congenital abnormality of the genitourinary tract you will find. MODY 12 is also important because that is one type of MODY which behaves like MODY 1 and 3, and we discovered that it responds to tablets just like MODY 3. The other MODYs are of more of academic interest because they don't respond. I'm not going to talk about the genetic syndromes like monogenic forms of diabetes. Now, since only some MODY respond to sulfonylurea, as a clinician, we are more interested in MODY 1 and 3 and maybe MODY 12. So my PhD student Aarthi Ramaswamy, she wrote this paper saying that why we should call them as actionable MODY. That is, these are the MODY which you really need to pick up as a clinician. The others are of academic interest. Now, how do we identify when a patient comes to us? Using what criteria do we decide who to send for genetic testing? Genetic testing is expensive. We try to do it free of cost for everybody wherever possible, but whoever pays for it, somebody has to pay for it, and it's not cheap. So how do we identify? In the world, there was no such criteria that you do this, and then you clinically select who to send for genetic testing, especially since type 2 diabetes is very common in our country. Whom do you decide how to go? So what we did was, in this large study, we took MODYs who were genetically determined to be to MODY 1 and MODY 3. We are more interested in that. So only MODY 1 and MODY 3 genetically confirmed. Nobody can doubt that this is MODY. And then compared them with about 1,000 type 1 people of the same age and about 1,600 type 2s of the same age and looked at all their clinical parameters. How do we diagnose it? Looked at age, BMI, HbA1c, HDL cholesterol, fasting C-peptide, stimulated C-peptide, looked at a few others as well. We tried to see which separates out the MODY from others. What we found was, it doesn't come out clearly here, is that the fasting C-peptide and the stimulated C-peptide, better shown here, was a much better predictor. The others were not having a good sensitivity and specificity. The fasting C-peptide is quite good, but the stimulated C-peptide, for which you just have breakfast and 90 minutes later take one blood sample, so which is what we do in the clinic anyway, postprandial sample. Along with that, you see whether it goes up or not. Beautifully, as I can show you in the previous slide, you can see the stimulated C-peptide. The dotted one is type 1, the green is type 2, and the red is MODY. So MODY is able to sit somewhere in between, and so with a very good sensitivity and specificity. So we concluded that in a clinical setting, if you have a C-peptide is too low, don't bother, it's type 1. If it's too high, it is type 2. If it's in the middle, then you, and if they have 3-generation transmission, then you can think of MODY if the antibodies are negative. While we are doing all this, we get these samples from all over the country. We are a national center, ICMR Center for Monogenic Diabetes. So we get hundreds of samples every day, and now we have started doing it free for almost everyone. So one gene which we are very interested in is the ABCC8 gene, because that is the one which produces MODY12. Because the KCNJ gene, which is also next to that, is also a beta cell gene. Now what happens is, this ABCC8 gene is very interesting. I told you about MODY12. Now if you have a mutation in ABCC8, it can be of two types. One, it can be a gain of function mutation, or it can be a loss of function mutation. If you have a gain of function mutation, this can occur in newborn children, and then we call it as neonatal diabetes. 2-month-old child, 3-month-old child, it has a gain of function mutation, it's neonatal diabetes. And that's the best thing to do, because that child can then be taken off insulin and treated with tablets. This can also occur in adults when you call it as MODY12. This also responds to sulfonylurea. So if you have a gain of function mutation, produce diabetes. Now there's an opposite thing. If you have a loss of function mutation, you actually get hypoglycemia. And we're getting hundreds of children like this. Newborn children going into hypoglycemia all the time, developing fits. They don't respond to glucose, they don't respond to anything. That's because they have a genetic defect. They need to be treated with diazoxide or octreotide, and we've got a large series of that. Now when we were screening some of our adult patients, young adult patients for MODY, we found that they had ABCC8 mutation. So we said, oh, it must be ABCC8 MODY12. But when we looked at it carefully, they had a loss of function mutation. We were very confused, because they should have had hypoglycemia and not hyperglycemia. So we did some studies, and then we reached out to the best people in the world, which is the University of Washington at Seattle. They have separate functional assays where you can look at loss of function and gain of function. And we wrote to them and said, we are confused, sir, because we are getting a loss of function mutation which is producing diabetes instead of hypoglycemia. Can you confirm this? So they took about a year, and they came back and said, you have made a discovery. This is the first time in the world that a loss of function mutation has produced diabetes. So we published this in Diabetes. It became very big news, because a big discovery from India that a new type of MODY, MODY15 we call it, has been, so we called it as paradoxical MODY arising from loss of function in ATP. It's the first time that a new type of diabetes has actually been described from this country. Now why does this happen? See, when you have a loss of function mutation, you get hypoglycemia. Why do you get hypoglycemia? Because you are producing more and more insulin. The beta cell is producing more and more insulin. So it will produce hypoglycemia. What we are saying is, and that leads to congenital hyperinsulinemia. What we are saying is that because of, so what we are saying is that when it keeps on hypersecreting like that, after some time the beta cell fails, because it's not able to produce so much of insulin. Then what will happen? You'll get diabetes. So that's the new type of diabetes due to a loss of function mutation. It's the first time in the world that this had been described. So we are now calling it as MODY15, and this is one of the new discoveries which we're very happy to be associated with.